once had a friend who told me that he's planning on getting a brain transplant. But then he changed his mind. And nervous systems are just so reckless. You know why? Because they do everything on impulse. Hello, everybody. It's Ryan here. I hope you and your family are well and everything is well at home. Thank you so much for joining me, even as we discuss a relatively common clinical topic in internal medicine, that of ischemic stroke. So this is the outline of our talk today. We're going to be covering a clinical case just to give us some degree of perspective and context into the clinical topic. Then we're going to delve into ischemic stroke, talk about etiologies, patient presentation, differential diagnosis, diagnostic evaluation in terms of investigations, treatment and management, prognosis and complications, and then I'm going to encourage you from the Bible. Thank you so much for joining me. So here's our clinical case. Let's get stuck in, guys. Let me just get my pointer in there. Okay, so we have a 68-year-old man who presents to the emergency department with right-sided face, arm, and leg weakness that has begun abruptly about 1 hour prior to arrival. Important to note the time frame, right? The patient is accompanied by his wife. He exhibits Broca aphasia and dysarthria. Physical examination confirms a dense hemiparesis of the right face, arm, and leg with decreased sensation. In addition, there is a gaze preference to the left. The patient's initial blood pressure on presentation is 195 over 115 mils mercury. Multiple follow-up blood pressures have been sustained between 160 to 170 systolic, and between 100 and 110 diastolic without treatment. An emergency non-contrast head CT shows no evidence of intracranial hemorrhage, with only mild loss of gray-white differentiation. On further review of the patient's medical history, he had a prior embolic stroke affecting the posterior circulation just 12 months ago. He also has a history of colon cancer that was diagnosed 3 months ago when he presented with a lower GI bleed requiring transfusion of 4 units of packed red cells. He successfully underwent left hemicolectomy of a stage 1 adenocarcinoma. During the post-op period, he developed a deep vein thrombus of a superficial femoral vein on the right. He is currently being treated with warfarin 5 mg daily. His last INR was therapeutic at 2.2. It was checked about 4 days ago. Now, which of the following factors is a contraindication for the use of intravenous tissue plasminogen activator on this patient? Is it A, GI bleeding within the last 3 months, B, initial blood pressure elevation of over 180 systolic or over 110 diastolic? Is it major surgery within the last 3 months? Option C. Is it D, prior embolic stroke, or E, the use of warfarin with the elevated INR? Okay, guys, let's get stuck into this. Let's talk about stroke, guys. An acute stroke is obviously a medical emergency requiring immediate management because time is brain. In acute coronary syndromes, time is muscle. In stroke, time is brain. Ischemic stroke constitutes about 80% of all types of stroke. The remainder of cases are, of course, hemorrhagic strokes, which are then sub-partitioned into being subarachnoid hemorrhage, intracerebral, and non-traumatic epidural or subdural hematomas. Now, thrombotic stroke is the most common type of ischemic stroke. Advanced age is the chief risk factor, but other risk factors include family history, and then, of course, you got the ischemic risk factors of diabetes mellitus, hypertension, dyslipidemia, cigarette smoking, cardiac disease or atrial fibrillation, carotid artery disease, alcohol use, and of course obesity. Many strokes are indeed preventable with appropriate risk factor modification. Looking at etiology, epidemiology, and risk factors, guys, the primary etiologies are thrombotic stroke, then you got embolic flavor, sometimes you got both. So thrombotic strokes are by and large the most common and occur due to atherosclerosis, and they can take the form of large vessel atherosclerosis or lacuna infarcts. And the lacuna infarcts refer to very small vessel occlusions which have limited neurological deficits, often giving rise to subcortical strokes. But large vessel atherosclerosis occurs usually at the bigger vessels, the carotid, the vertebral, the basilar arteries. Arterial dissection is the most common cause among younger folks, usually on account of trauma. Hypercoagulable states like the antiphospholipid antibody syndrome, autocontraceptive use, pregnancy, etc. must also be borne in mind. Right, the artery of origin may be intracranial, example lacuna infarcts, or extracranial, example the carotid or vertebral stenosis or occlusion. Right. Now, embolic strokes. Embolic strokes may be arterial in the way of aortic arch atheroma or artery-to-artery embolus, or cardiac in the way of post-myocardial infarct with the LV thrombus which has embolized, or atrial fibrillation or valvular heart disease in origin. Don't forget infective endocarditis. It may be associated with hypercoagulable states or paradoxical emboli through a patent foramen ovalia PFO. Okay, the vascular territory involved determines associated neurological deficits. Right, so to this end, carotid ischemia results in an anterior circulation stroke. We're going to see a beautiful diagram coming up, which then causes dysfunction of the cerebral hemispheres and the eyes. Whereas vertebral basilar ischemia results in a posterior circulation stroke, causing dysfunction of the posterior fossa. So you want to do your CT brain with the posterior fossa views, especially the cerebellum and brainstem, portions of the temporal lobe, and the occipital lobe. TIA is a transient ischemic attack. It's a strong risk factor for subsequent stroke. This is our beautiful circle of Willis. Just a quick rehash of this, showing us basically the perfusion of the brain. Okay, so we have three main. Let me just skip my pointer in there to demonstrate. So we got the big arteries coming up from the aorta, which supply the brain, being the vertebral artery, to the posterior circulation, which gives rise to the basilar artery. And then we have the internal carotid, right, at the front. So the internal carotid basically, which is here, it gives rise to the anterior cerebral, right, as well as the middle cerebral here, right? And then between the anterior and the middle cerebral is the anterior communicating artery. All right, and then of course the vertebral arteries, there's two of them, gives rise to the basilar artery, which then continues upwards and gives rise to the posterior cerebral. And between the middle and the posterior cerebral is the posterior communicating artery. Alrighty. So in terms of our clinical classification of stroke, they come in a variety of flavors. So you've got the total anterior circulation stroke, the partial anterior circulation, the posterior circulation, and the lacuna syndrome. Okay. So in terms of a total anterior circulation stroke, this usually is because of thrombus or embolus affecting the carotids or the anterior cerebral, right, or the middle cerebral. And this usually gives you hemiparesis, hemianopia, and a higher cortical deficit. So it gives you a cortical deficit. Lacuna strokes do not give you cortical deficit. And examples of cortical deficit is dysphasia and visuospatial loss. Okay, if it's a partial anterior circulation stroke, then you have two of the three components of the total anterior circulation stroke, or you have isolated higher cortical deficit or motor or sensory deficit more restricted. So if you've got a posterior circulation stroke, these tend to be quite challenging at times, but they give the following features: ipsilateral cranial palsy with contralateral motor and sensory deficit, or bilateral motor and sensory deficit, or disorder of conjugate eye movement, or cerebellar dysfunction with ipsilateral long tract deficits, or isolated homonymous hemianopia. If we're dealing with the lacuna syndrome, we said these are very small vessels, right, which usually give you subcortical strokes on the basis of lipohyalurosis, right? It can be pure motor stroke, which is 2 out of 3 for face, arm, and leg, or pure sensory, which is more than 2 out of 3 for face, arm, and leg, or pure sensory motor, more than 2 out of 3 for face, arm, and leg, or ataxic hemiparesis. But guys, if you were to go back to the circle of Willis, right, if you have an anterior cerebral artery stroke, typically it gives you a clinical distribution of weakness that affects the legs more so than the arm and face. Legs more so than the arm and face. If you've got involvement of the middle cerebral artery, it'll give you involvement of the face and arm more than the leg. If you've got an internal capsule stroke, which is usually a lacuna stroke, we have equal weakness of the face, arm, and leg. All right. Posterior circulation stroke has various permutations affecting the brainstem and cerebellum. All right, so that's that. Yeah, this is Harrison's breaking down the common causes of stroke. I just want to mention a few. So we say under thrombosis, we have lacuna strokes, which are lacuna strokes, which are small vessel, and then large vessel thrombosis and dehydration. Embolic occlusion can be artery to artery, cardioembolic and paradoxical, like we mentioned. Then we have other causes as well. Uncommon causes include your hypercoagulable disorders. These come in so many different flavors. Protein CNS deficiency, antithrombin 3 deficiency, antiphospholipid antibody syndrome, which gives you a combination of venous and arterial clots, okay? Together with that history of prior miscarriages, right? And there are specific criteria for that, which we will look at in a different video. Factor V latent deficiency, prothrombin G20-210A mutation, systemic malignancy, sickle cell anemia. Then you got your hematological issues, sickle cell anemia, beta thal, polycythemia. Then we got systemic lupus erythematosus, homocystinemia, TTP, DIC, dysproteinemia, nephrotic syndrome because you ping out your protein C and S, inflammatory bowel disease, oral contraceptive. Don't forget COVID-19, the new kid on the block. Don't forget about venous sinus thrombosis, fibromuscular dysplasia, a whole truckload of vasculitic syndromes, non-inflammatory vasculopathy, cardiogenic, right? Especially Lipman Sachs. Don't forget, SLE causes LSE. Systemic lupus erythematosus causes Lipman Sachs endocarditis. Subarachnoid, hemorrhage, vasospasm, moya, eclampsia. Okay, guys, let's look at risk factors for stroke as per Harrison's, and this just demonstrates, right, risk factor and the relative risk. So hypertension, as we know, is big. Okay, 38% relative risk reduction with treatment. And this gives us a corresponding number needed to treat. Atrial fibrillation, diabetes, smoking, hyperlipidemia, asymptomatic carotid stenosis, symptomatic carotid stenosis, and which is between 70 to 99%. Relative risk reduction is 65% at 2 years versus symptomatic carotid stenosis, 50 to 69%. Relative risk reduction is 29% at 5 years. Okay, guys, let's look at how do patients present. So usually we have the abrupt onset of negative symptoms such as visual loss, paresthesias, and numbness. Headache occurs in upwards of 25% of cases. Severe headache, particularly with loss of consciousness. Seizure or progressive deficits may occur with hemorrhagic stroke. Usually it's a devastating catastrophic event. Severe headache in association with Horner syndrome with recent trauma history suggests arterial dissection, especially in the youngsters. Watch out for that. Anterior circulation stroke, we already covered this, reveals focal weakness, sensory alterations, and aphasia. Posterior circulation stroke often have more complex presentations, and we mentioned this, right? Amaurosis fugax is a strong indicator for carotid artery disease. You want to do a carotid Doppler and look at your degree of stenosis. TIA symptoms usually resolve within an hour, right? And we have our beloved NIH stroke scale. So this is devised basically for physicians to ask patients a variety of questions and do a couple of tests, and it grades the severity of the stroke. The scale is made up of 11 different elements that evaluate specific ability. The score for each ability is a number between 0 and 4, with 0 representing normal function and 4 being completely impaired. And you can see it's split here into all these different parameters essentially, okay? And the final score is out of 31. Differential diagnosis for ischemic stroke, guys, can be hemorrhagic stroke, complicated migraine, seizure being post-ictal state or TODS produces, hypertensive urgency or emergency, hypo and hyperglycemia representing a metabolic cause, syncope, positional vertigo. It could be a brain mass like a brain tumor, multiple sclerosis, meningitis, encephalitis, brain abscess, or a space-occupying lesion in the context of someone who's immunocompromised. So this then we think about tuberculoma and aspergilloma and toxoplasmosis and lymphoma, drug overdose, trauma, conversion hysteria, Bell palsy, or a mononeuropathy. Okay. Now this essentially represents major steps in the cascade of cerebral ischemia to go into the pathobiology of it, right? So we have arterial occlusion, which then gives rise to ischemia and energy failure because you can't get your blood, you can't get your oxygen, you can't generate ATP, right? And then the patient probably undergoes thrombolysis and thrombectomy and reperfuses. When that happens, it instigates an inflammatory response causing leukocyte adhesion and arachidonic acid production, all right? Now, also, you have glutamate release, and this influences the glutamate receptors to cause calcium and sodium influx, which stimulates proteolysis and membrane and cytoskeletal breakdown, leading to cell death. But the calcium and sodium influx also causes mitochondrial damage and production of nitric oxide, and which then fuels free radical formation and lipolysis and further increases the arachidonic acid production. Lipolysis also causes phospholipase, which contributes further to membrane and cytoskeletal breakdown. Alrighty. Free radicals also contribute to poly-A ribose polymerase, which contributes further to energy failure. All right. So here we're looking at more the pathophysiology once more. So diagram A, let's just get my pointer in there, demonstrates the three major mechanisms which underlie ischemic stroke. So firstly, we get occlusion of an intracranial vessel by an embolus or by a cardiogenic source, right? Such as atrial fibrillation or artery-to-artery emboli from carotid atherosclerotic plaque, often affecting large intracranial vessels. The second way is with in situ thrombosis, All right, in situ thrombosis of an intracranial vessel, typically affecting the small penetrating arteries that arise from the major intracranial arteries. The third mechanism is hypoperfusion caused by flow-limiting stenosis of major extracranial or intracranial vessels, producing so-called watershed ischemia. Okay, in B and C, what we have is a diagram as well as a reformatted CT angiogram of the common carotid, internal and external carotid arteries. High-grade stenosis of the internal carotid artery, which may be associated with either cerebral emboli or flow-limiting ischemia, was identified in this patient. Guys, how do we work up patients who have ischemic strokes? So prompt diagnostic workup should be performed in all TIA and stroke patients. Essentially, all patients should be admitted to hospital, undergo a thorough history and neurological exam, which are the basic tenets of medicine. And then initial lab studies include a full blood count, glucose, lipogram, homocysteine level, and CRP. Coagulation profile is indicated among youngsters. Brain CT without contrast is indicated to evaluate for hemorrhage, tumor, and infarct. However, acute infarcts will not declare on a CT scan at least 24 hours after the onset of weakness, right? So the main reason we are doing the CT is to rule out a hemorrhage with a view to administering TPA, right? MRI with diffusion weighting will reveal an acute infarct within minutes of occurrence and is better for visualizing the brainstem, right? Echo to assess for a cardiac source. The transesophageal echo is much more accurate than is transthoracic to detect cardiac emboli. Now, CT or MRI are used to evaluate for extra and intracranial stenosis or occlusion. Carotid and vertebral Doppler studies are also used to evaluate for arterial stenosis or occlusion. Catheter angio is now used less frequently, but is still the gold standard to diagnose arterial stenosis and carries a 1% risk of actually causing a stroke. Okay, so here we can see some images in coronal and cross section, illustrating the deep penetrating arteries. Here, the deep penetrating arteries involved in small vessel strokes. In the anterior circulation, right, small penetrating arteries called lenticular striates arise from the proximal portion of the anterior and middle cerebral arteries and supply the deeper subcortical structures. The point here is that they are subcortical structures. So if you have lacunae infarcts, they're not going to give you cortical signs. All right. In the posterior circulation, like we see here, the vertebral and basilar circulation, similar arteries arise directly from the vertebral and basilar vessels to give rise to a discrete area of infarct, also lacunae infarcts. Note that these vessels are too small to be visualized on CT. Alrighty guys, so how do we manage? Acute therapy includes stabilization of glucose and blood pressure. You want to treat the elevated blood pressure only when it goes above 220 mils mercury systolic and or 115 millimeters mercury diastolic, because hypertension is actually necessary to maintain cerebral perfusion. You do not want to lower the systolic blood pressure to below 180 mils mercury, right? Otherwise, you're going to extend the territory of the infarct. There is an area around the infarct called the ischemic penumbra, which depends on proper blood pressure to perfuse. If you drop the blood pressure too soon or too quickly, you're going to extend the territory of the infarct into the penumbra region. All right. Thrombolytic therapy in the way of tissue plasminogen activator may be indicated if within 3 to 4.5 hours of symptom onset. Thrombolytic therapy carries a 6% chance of inducing hemorrhage. Anticoagulation with heparin is often used, but there is no evidence to support its use or that it improves outcomes. Secondary prevention includes antiplatelet therapy with aspirin, clopidogrel plus aspirin in the case of reinfarct. So if this is a reinfarct, then we want to consider dual antiplatelets. Statin therapy for hyperlipidemia and blood pressure control. And of course, proper glycemic control. If the patient's diabetic, advise them to stop smoking, etc. If a cardiogenic source is found, example atrial fibrillation, then chronic anticoagulation with warfarin is indicated. Carotid endarterectomy or percutaneous stenting is indicated in cases of carotid stenosis with more than 70% stenosis in that culprit artery. Okay, here is a management algorithm from Harrison's. So if you suspect an acute stroke, we got a call beforehand, before the patient arrives, and do code stroke activation. If the onset is within 6 hours, do a CT if it shows no hemorrhage, and if tissue plasminogen activator is available and the patient has no contraindications, you give tissue plasminogen activator and then perform a CT angiogram. But if you missed the boat and the onset of weakness was probably 6 to 24 hours beforehand, and the CT shows no hemorrhage, right, and if there's favorable perfusion, then then you want to consider ICA, right, and maybe thrombectomy. But if no, we just do inpatient management. But usually, the window for thrombolysis after the onset of weakness is 3 to 4.5 hours, right? But this algorithm gives us 6 hours. Just a little bit about administration of IV recombinant tissue plasminogen activator. We know that its indication is the clinical diagnosis of stroke. Onset of symptoms to time of drug administration must be within 4.5 hours. And in this time, you must have had a CT scan which demonstrates no hemorrhage or edema up to over a third of the MCA territory. Age above 18 years. Contraindications is sustained blood pressure above 185 systolic and or diastolic of 110 mils mercury despite treatment, bleeding diathesis, recent head injury or intracerebral hemorrhage, major surgery in the preceding 14 days, GI bleeding in the preceding 21 days, recent MI. And this basically gives us advice on how to administer recombinant tissue plasminogen activator. You need IV access with 2 peripheral IV lines. You don't want to really give it into a central line. Review eligibility in terms of ruling out contraindications. Take consent. Administer 0.9 mg per kg up to a ceiling dose of 90 mg IV as 10% of total dose by bolus, followed by the remainder of the total dose over 1 hour. Frequent blood pressure monitoring. No other antithrombotic treatment for 24 hours. For decline in neurological status or uncontrolled blood pressure, stop the infusion, give cryoprecipitate, and re-image the brain emergently, because that probably would have been a hemorrhage. Avoid erythrocatheterization for more than 2 hours, right? Guys, in terms of prognostication and complications, 20% of patients with an ischemic stroke have immediate mortality. 70% will thereafter have some degree of disability. Recurrence of stroke occurs at about 10% per year in those who are untreated. Antiplatelet agents go a long way in terms of a reduction in the rate of stroke recurrence by about 20%. Statins and blood pressure control, especially ACE inhibitors, reduce recurrence by a whopping 30%. Further risk factor modification includes smoking cessation, weight loss, and exercise, and appropriate management of glycemic control in those who are diabetic. 50 to 70% of patients will eventually regain dependence. Upwards of 80% regain the ability to walk. Nearly 50% of stroke patients will eventually die of myocardial infarct. Physical, occupational, and speech therapy are extremely helpful, right? We got to employ the services of our allied disciplines. Deep vein thrombosis, decubitus ulcers, and hypostatic pneumonia are complications. Okay, guys, just to rehash this case, it was quite a long stem, but to get the gist of it, we had an elderly gentleman who came in with right-sided face, arm, and leg weakness, so it's probably a left MCA stroke, right? He has extremely high blood pressures. Emergency CT shows no hemorrhage. He also has a history of colon cancer. He underwent hemicolectomy not too long ago. In the post-op period, he developed a DVT, and he's on warfarin 5 mg daily, and he's got a therapeutic INR. Which of the following factors is actually a contraindication to the use of IV TPA on this patient? The answer here is use of warfarin with elevated INR. So this patient is presenting with symptoms of acute stroke affecting the MCA territory. Now, findings on past medical history that would constitute a contraindication to the use of recombinant tissue plasminogen activator include prior stroke or head injury within the past 3 months. That's a no-no. Any prior history of intracranial hemorrhage, major surgery in the preceding 2 weeks, GI bleeding in the past 3 weeks, recent MI, or individuals who have a platelet count below 100, hematocrit below 25%, use of heparin within the past 48 hours, or prolonged APTT, which is activated partial thromboplastin time, or raised INR. They should also not receive recombinant tissue plasminogen activator. My friends, I hope that you allow me to just spend a few moments talking to you about Scripture. Today we're talking about anger. The book of Proverbs chapter 29 verse 11 says, "Fools vent their anger, but the wise quietly hold it back." Psalm chapter 4 verse 4 to 5 says, "Do not sin by letting anger control you. Think about it overnight and remain silent." One of the characteristics of the Holy Spirit in the life of a person, one of the fruit of the Holy Spirit is self-control, right? And the book of James admonishes us by telling us, be quick to listen, slow to speak, and slow to become angry, because anger does not allow one to fulfill God's purpose for their life. Human anger needs to be restrained and controlled by the power of the Holy Spirit. And I pray this upon you and myself as well. These are my references, everybody. Remember, you can catch me on Facebook. Just search for Internal Medicine, Algorithms, and Mnemonics. You can also find me on TikTok, on Instagram as well. God bless you. Thank you so much for joining me. We're going to be covering some exciting topics coming up. Tuberous sclerosis. We're also going to be touching on gout and hyperuricemia. Right? And yeah, thank you so much. Looking forward to seeing you soon. Take care and have a lovely day.